Every year, millions of babies are born worldwide, and roughly 10% will need some degree of assistance to breathe at birth, while only 1 in 1,000 will need extensive measures like chest compressions. Forget everything you need or you know about adult CPR. In adults, the heart fails and the lung stops. In newborns, the lung fails and the heart stops. This lecture is not about cardiac compression, it's about the power of effective ventilation. So our preparation dictates whether that transition is seamless or catastrophic. Let us discuss about neonatal resuscitation. Neonatal resuscitation means reviving or restoring life of a baby who is unable to establish adequate breathing at birth. 10 to 50% of newborns need some assistance and only less than 1% require extensive resuscitation. When we came to physiology of neonatal transition, fetus depends upon the placenta for gas and the nutrient exchange. Placenta has the lowest vascular resistance and receives 40% of fetal cardiac output. Fetal lungs are filled with fluid, resulting in a high vascular resistance and less than 10% of cardiac output going to the lungs. The initial crying and the deep breaths should be strong enough to help move the fluid from the airways. With first breath, lung expands and pulmonary pressure drops. The blood vessels in the lung tissue relax and pulmonary blood flow increase. An uncomplicated transition from fetal to newborn status is characterized by loss of fetal lung fluid, secretion of surfactant, establishment of functional residual capacity, decrease in pulmonary vascular resistance, and increased systemic pressure with increase in pulmonary arterial blood flow. Signs of abnormal transition include depression of respiratory drive, poor muscle tone, cyanosis, bradycardia, poor perfusion, and tachypnea. We can classify risk factors associated with need for resuscitation as antepartum and intrapartum risks. Antepartum risks include chronic maternal illness, preeclampsia, maternal infection, PROM, IGR, preterm, old or young age of the mother, anemia, fetal malformation, no ANC follow-up, postpartum pregnancy, multiple pregnancy, the maternal substance abuse, and others. Intrapartum risk include emergency CS, instrumental delivery, abnormal position, premature labor, precipitated labor, prolonged second stage of labor, non-reassuring fetal rate pattern due to general anesthesia, narcotic administered within 4 hours of delivery, meconium stained liquor, prolapsed cord, antepartum bleeding, and others. Before the birth of a baby, sufficient preparation for birth should occur. At least one individual capable of neonatal resuscitation will be present at the delivery. Those are equipment and the supplies for neonatal resuscitation. We should have to prepare those things before delivery. Bag and the mask equipment, intubation equipment, medications, and the miscellaneous. Basic steps in resuscitation include thermal management, clearing the airway, tactile stimulation, establishment of ventilation, chest compression, and the medication. Newborns who do not qualify for routine care should be placed in warm blankets and quickly moved to a preheated radiant warmer set at 100% power. The infant should be thoroughly dried and the wet blanket should promptly removed. Then, if the infant has excessive secretions, position head and the clear airway as necessary by placing the newborn on the back with head in midline position and with slight neck extension. That's called sniffing position. Sanction the mouth first, then the nose. Mouth, then nose. M before L, gently and briefly by sanction bulb or large bore sanction catheter. Avoid hyperextension and flexion of the neck. The right positioning is the sniffing position. So first sanction the mouth, then the nose. Mouth first, then nose. This is followed by tactile stimulation. Apply tactile stimulation by gently rubbing the back or flicking the soles of the feet 2 to 3 times. Ventilation of the lung is the single most effective step in newborn resuscitation. We call it positive pressure ventilation. If there is no response with the above methods, start bag and mask ventilation within the golden minute. Indication to start positive pressure ventilation is no breathing or gasping breathing, apnea, and heart rate less than 100 despite apparent respiratory failure. Call for help and take the resuscitation table. Position the infant correctly with slight extension at the neck. Position the mask correctly and apply a firm seal. Just provide 5 breaths and check for rising heart rate. If absent, adequate chest movement should have to present. If there is no adequate chest rise, take ventilatory corrective steps, which is called Mr. Sofa. M stands for mask adjustment in the face. R is repositioning the head to open airway. S is sanctioning mouth and then nose. O is opening mouth and lift jaw forward or reattempt to ventilate. If not effective, then pressure increase every breathes until visible chest rise is noted. And artificial airway. Once effective ventilation starts, continue for 30 to 60 seconds at 40 to 60 breaths per minute. In term infantis, initiate resuscitation with 21% oxygen. If blended oxygen is not available, it should be initiated with room air. In preterm babies, use blender with 21 to 30% oxygen. Evaluate the heart rate after 30 to 60 seconds of bag and mask ventilation. If heart rate is above 100 and infant has spontaneous respiration, discontinue ventilation. If heart rate is between 60 to 100, use corrective steps of ventilation. If heart rate is less than 16, ensure ventilation with 100% oxygen and initiate chest compression. Pass orogastric tube if bag and mask ventilation is continued for more than 2 minutes. If a baby starts to breathe but oxygen saturation is not within target range, free flow oxygen administered may begin at 30. If the newborn has labored breathing or saturation cannot maintain with target range despite 100% free flow oxygen, consider trial of CPAP. Indication for endotracheal intubation include bag and mask is ineffective or prolonged before chest compression, extremely low birth weight for administering surfactant, tracheal administration of medication if desired, and congenital diaphragmatic hernia. If heart rate is less than 60, despite good assisted ventilation for 60 seconds, go for chest compression. In case of 2%, one to perform chest compression and the other to continue ventilation. You can do chest compression in 2 times encircling hands method or the 2-finger technique. The rate is 30 breaths per minute and 90 compression per minute. So the ratio of compression to ventilation is 3 to 1. The compression depth is 1/3 of the chest diameter. After 60 seconds of chest compression, check the heart rate. If heart rate is less than 60 per minute, continue compression and ventilation and initiate medication. Intubate if possible. Epinephrine is indicated when heart rate remains less than 60 after 30 to 60 seconds of effective ventilation and another 60 seconds of coordinated compression and ventilation. The dose is 0.1 to 0.3 ml per kg IV or 0.5 to 1 ml per kg through ET tube of 1 in 10,000 epinephrine solution, which might be repeated every 3 to 5 minutes if required. Endotracheal route is easier, but IV is preferred. Volume expansion is considered when blood loss is known or suspected, such as acute bleeding, poor response to resuscitative birth, half pallor and shock in the delivery room. Just give 10 ml per kg of NS bolus, which can be given through peripheral vein over 5 to 10 minutes. If clinical improvement is not seen, cause of further blood loss should be sought and the blood replacement should be considered. Infants who require resuscitation are at risk for deterioration after their vital signs have returned to normal. Once adequate ventilation in the circulation has been established, stop ventilation, return to mother for skin-to-skin contact as soon as possible. Closely monitor breathing difficulties, signs of asphyxia, and anticipate need for further care. It is appropriate to consider discontinuing resuscitation after effective resuscitation effort. Just for example, if infant is not breathing and the heartbeat is not detectable beyond 10 minutes, you can stop resuscitation. If no spontaneous breathing and heart rate remains below 60 after 20 minutes of effective resuscitation, you can discontinue active resuscitation. This is a summary of neonatal resuscitation. Thank you for watching.